بس خلي المايكات قريبة مشان يطلع الصوت صح من عند حضراتكم بعد إذنك.
Okay.
شكرا.
Thank you. The second session of our conference is Friday. Today is Friday, 10 March. We will start about the interventional cardiology with one of our guests from England. He was talking about high-risk bleeding patient. He is from academic research of consulting of high bleeding risk. Just a few words about our friend. We are taking up this post. He was consultant interventional cardiology at the West Scotland Regional Heart and Lung Centre. He has also a significant experience in both TAVI and multi-clip procedure. He is from University of Glasgow. His own research interests include clinical and experimental assessment, novel drug-eluting stent, and the use of invasive physiology index of stenosis severity to guide decision-making in this cath lab. He has been a principal investigator on several international trials, including FAM2, PRAMI, LEADERS, TTT, patati patata. In 18, he received Lifetime Achievement Award from the British Cardiovascular Interventional Sociology and with Sir James McZardy. So thank you for his help to our conference. He can start if we are online.
Okay, thanks very much. So I hope you can hear me, and I hope you can see the slides. So I will just kick off now. Obviously, my main conflict of interest now is that I'm the Chief Medical Officer for Biosensors International. So high bleeding risk started, of course, with the LEADERS 3 trial, which, as you know, was a randomized double-blind comparison of the BioFreedom stainless steel stent against bare metal stent comparator. And because both stents were provided by the same manufacturer, it was possible to double-blind the study. And the safety endpoint was powered for non-inferiority, so it was expected that this cardiac death MI stent thrombosis rate would be the same in both groups. But of course it turned out that it wasn't. It was 12.9% with the bare metal stent group, and actually it was lower with the BioFreedom stent, which surprised everybody, particularly as both groups only got 1 month of DAPT. And this study launched the interest in high bleeding risk patients because every single patient in this study had a high bleeding risk. And you can see here the hazard ratio and a p-value of 0.005 for superiority. A couple of years ago, Medtronic did everybody a great service by doing another randomized trial. This time they compared BioFreedom against the Resolute Onyx stent. See it published here in the New England Journal of Medicine. We also took part in this study. And here's the primary endpoint at 2 years for cardiac death, MI, and stent thrombosis. So exactly the same endpoint at LEADERS 3, again in 100% high bleeding risk patients, but a very modern stent, the Resolute Onyx, against the older BioFreedom stent. Absolutely no difference at 2 years in cardiac death, MI, or stent thrombosis. Also, absolutely no difference in target lesion failure, as you can see here, out to 2 years. Now, interestingly, there was a difference in the hardest secondary endpoint of all-cause mortality here on the left. You can see this difference, p-value 0.025, in favor of BioFreedom, so the all-cause mortality was less with the BioFreedom. The absolute risk reduction was 3.5%, the relative risk reduction was 22%, number needed to treat 29. And although this was a secondary endpoint, the post-hoc power was quite high at 62%. So this is a very good result, obviously, and speaks to the possibility that the polymer-free platform is safer than devices that have either permanent or biodegradable polymers. Actually, there was also a 22% relative risk reduction in cardiac death, meaning at least probably at least half the reduction was due to cardiac mortality. Now, we did lose a little bit on TVR with the biofreedom, probably because of strut thickness, but this has been addressed, as I'll show you later. Now, of course, if we come back to the high bleeding risk inclusion criteria in leaders 3, age over 75 was in 2/3 of the patients, and the need for oral anticoagulation was in 1/3 of the patients. And this is pretty classic, 1.7 high bleeding risk criteria per patient. These are the high bleeding risk inclusion criteria for Onyx 1. They used exactly the same criteria as leaders 3, and they got exactly the same. Age over 75 was the main risk, and need for oral anticoagulation was second. Now, the Academic Research Consortium had a look at all of the data on high bleeding risk and published this consensus document in the European Heart Journal in 2019. And what they did was slightly redefine the definition of high bleeding risk. So they created a series of major criteria for high bleeding risk on the left-hand side here and minor criteria on the right. And as you'll see, need for long-term anticoagulation stayed as a major predictor, but age over 75 was relegated to a minor predictor. Similarly, with renal failure, severe or end-stage CKD, so an EGFR less than 30 or a hemoglobin less than 11 were both major, but moderate CKD or moderate levels of anemia were now minor criteria. So the ARC-HBR criteria are not quite the same as was used in leaders 3 or in the Onyx 1 trial. So to validate these new criteria, these new ARC-HBR criteria, we took the data from leaders 3 and leaders 3-2, which is another study that was done using the biofreedom for US FDA approval, and we pooled them together. And there are some differences between ARC-HBR and what we recorded in leaders 3, 1, and 2, but we did some approximations. So for instance, cirrhosis and portal hypertension, which is a major bleeding risk, in the leaders 3 trials that was defined as any severe liver disease. So we matched these criteria as well as we could. When you do that, you find that about 80% of the patients in leaders 3, 1, and 2 met these new revised ARC-HBR criteria. So not 100%, but 80%. If you take those patients and you replicate the analysis from leaders 3, 1, and 2 for this endpoint of cardiac death, MI, and stent thrombosis, you still see this major benefit for the biofreedom stent with a hazard ratio of 0.72, P equals 0.006. If you look at the BARC 3 to 5 bleeding, you can see that these ARC-HBR criteria do work. They pick out a group of patients who are at even higher risk of bleeding than the patients in leaders 3, 1, and 2 who do not meet the new ARC-HBR criteria. So in the red line, these are the ARC-HBR patients, and in the blue line, these are the non-ARC-HBR. Now, they were still high bleeding risk according to the definition leaders 3, 1, and 2, but now you've got a hazard ratio for the ARC-HBR of almost 2.5. A very, very highly statistically significant difference. So this validated ARC-HBR in the original leaders 3, 1, and 2 studies. Now we've got a validation published in JACC in a completely different population. So this is just a large PCI database. It's mainly from Mount Sinai Hospital in New York, with where Roxana Moran leads the academic service. And their definition was bleeding during index hospitalization or post-discharge bleeding. So they looked at bleeding around about the procedure and bleeding after discharge. And you can see here For the major criteria, major ARC HBR criteria, the most common one was moderate or severe anemia, followed by oral anticoagulation, so that's slightly reversed from what you normally see. For the minor criteria, of course, age over 75 is still the most common. And the results are pretty spectacular. So first of all, this is the primary bleeding endpoint at 1 year. And you can see, if you compare HBR against non-HBR using these ARC criteria, now we've got a hazard ratio of over 3. So the ARC HBR criteria pick out a population who've got 3 times higher incidence of bleeding at 1 year. It's pretty dramatic. The more HBR criteria you get, the more in-hospital bleeding. You can see this gradient of risk. So if you have none versus 1, 2, 3, or 4 high bleeding risk criteria, you see this gradient of risk. And eventually, if you have 4 or more, the hazard ratio for in-hospital bleeding is 11 times higher. And similarly for post-discharge bleeding, so this is not just peri-procedural bleeding, this also predicts post-discharge bleeding with a hazard ratio at the top end here of over 15 times increased risk if you have 4 or more high bleeding risk criteria. Even more importantly, here we have at the top all-cause mortality. So the most robust endpoint in any clinical study, all-cause mortality. And as you go from no HBR criteria up to 4, you see this gradual increase in the all-cause mortality. Look at this here. 34 times risk of all-cause mortality if you have 4 or more HBR criteria. And that's despite using all of the techniques that we have to reduce bleeding risk with radial access and short DAPT and so on. And also for myocardial infarction, not quite as steep a gradient, but still somewhere approximately of 4 times the hazard ratio. So really pretty dramatic validation of the ARC HBR criteria and their ability to predict hard outcomes like all-cause mortality and MI as well as bleeding. Now, of course, we've got the trade-off between bleeding and thrombosis. So you know that if you're at high risk of bleeding, you're also at high risk of thrombosis, and that's the problem. There's a balance, there's a trade-off. So the data from a large number of trials, Century, Zeus, Leaders 3, Leaders 3-2, Senior, which was a study of patients aged over 75, and Paris, so there was an antiplatelet study. These were used to derive this trade-off model that I'm going to show you in a moment, and it was validated courtesy of Medtronic by using the data from Onyx 1. So I'll just walk you through how this works. It's pretty simple. Here you see this classic data showing that if you have a BARC 3 to 5 bleed, the 1 year mortality is in the yellow line, and if you have and the risk of death after an MI or a stent thrombosis is in the blue line. So whether you bleed or whether you have an MI or a stent thrombosis, so bleeding versus ischemia, at 1 year you have a very similar and very high mortality of somewhere in the range of 25%. But of course, for an individual patient, the bleeding risk may exceed the ischemic risk, or the ischemic risk may exceed the bleeding risk. It's never the same for an individual patient. In fact, 44% of these patients had a higher risk of MI stent thrombosis than a bleeding risk, 23% had a higher risk of bleeding than MI, and about 1/3 had a comparable risk of both events. So when you've got all of this data and you've got these individual rates of bleeding and ischemia, you can personalize your decision making. And just to show how good this model is at predicting, so here we've got bleeding on the left side and MI or stent thrombosis on the right. The dark columns are the observed rates and the lighter columns are the predicted rates. And you can see for these 5 quartiles of risk, the observed matches the predicted very, very closely. So how do we use this in clinical practice? Well, we can use it very, very easily because in the ARC HBR app now, which has been around for a while, we now have this bleeding versus thrombosis trade-off. So this is an app you can download onto your iPhone or your Android mobile device, and you can use every day of the week in clinical practice. It's a free of charge app. So if you enter data into this app, so for instance here we've got a patient who is more than 65, diabetic, prior MI, it's an MI presentation, the PCI is complex, and the patient is in atrial fibrillation and needs oral anticoagulation. You plug in this data, and you get a graph like this, and the red circle is our patient, and this patient is in the blue zone here. That means that the risk of MI or stent thrombosis is higher than the risk of bleeding. Here we've got on the right-hand side a different patient, still more than 65, still an MI presentation. This time they're anemic, they've got moderate renal impairment, but they still need an oral anticoagulation. So relatively similar, but more bleeding risk because of anemia and impaired renal function. This patient is now in the yellow zone here. The yellow zone means that the risk of bleeding is greater than the MI or stent thrombosis risk. So you can use this information to personalize decisions. Let me just walk you through one case. So here we've got a 65-year-old female, type 2 diabetic. She's got paroxysmal atrial fibrillation, a previous stroke and thrombocytopenia. So you're getting warning bells already. This is high bleeding risk. Psoriatic arthropathy, so probably taking non-steroidals. Some learning difficulties. Known to have coronary disease, had a BX sonic stent long time ago, implanted by me in the proximal IVA in 2003. Comes in with a non-STEMI, gets an angiogram, very, very poorly tolerated, very small radials, but eventually we do the angiogram with a 4-French sheathless system from the left radial artery. And we find that she's got a critical osteosarc lesion, which I'll show you in a moment. And we didn't even manage to visualize the right coronary artery. So we have to decide what we're going to do. So we go to the ARC thrombosis bleeding trade-off app here, and we plug in this information, and what do we find? We get 1 year risk of MI and stent thrombosis in this patient is 10.7%. And despite all the high bleeding risk criteria that she's got, the 1 year risk of bar 3 to 5 bleeding is actually lower. It's only 3.6%. So there's more risk of MI and stent thrombosis than there is of bleeding here, but actually they're both high. Both of these risks are high. So we decide to go for a simple stent strategy. We use a stent that we know is safe in high bleeding risk patients with short DAPT. Of course, what do we go for? We go for the BioFreedom Ultra, the cobalt chromium version of the BioFreedom, CE marked in October 2020. Here's the angiogram. So you can see this osteocircumflex stenosis. Now, of course, you could make this complicated by going from the circumflex back into the left main, and then you probably have to do a case, so you might end up having to do a culotte or a tap stent into the LED, who knows. Here's another view just to give you a slightly different impression. But we wanted to keep it simple because we wanted to give short DAPT, 1 month only. So we place a single BioFreedom 3.0 by 14 millimeter stent in the ostium of the circumflex. We do not cross into the left main. We check it with IVIS guidance, and we get a very nice result. But we're not finished, because now we have to decide what we're going to do after the procedure. So remember, this patient needed oral anticoagulation. So are we going to use triple therapy, and for how long? Are we just going to use DAPT alone, and for how long? We could use a NOAC with a single antiplatelet drug, or we could use use a NOAC alone, no antiplatelet therapy whatsoever. So using the information that we had from the trade-off model, knowing that this patient had high risk of both ischemia and bleeding, 10.7% risk of ischemia, stent thrombosis, 3.7% of bleeding, we went for a NOAC with a single antiplatelet agent, so no triple therapy and no DAPT for any period of time, and I'm pleased to say that this patient did extremely well. So I'm going to conclude now by just encouraging you to think about using the RHBR thrombosis versus bleeding trade-off model. It's well validated, it's available as an app, it's easy to use, it facilitates personalized decision making, and it definitely impacts on your PCI strategy and your stent choice and the anticoagulation and antiplatelet therapy regime that you choose for the patient, as I've shown you here. But importantly, you have to use it before you enter the cath lab. There's no point in finding out, you know, after you've just put in 4 or 5 or 6 stents in a high bleeding risk patient that actually she is high bleeding risk, and that if you keep the DAPT going for too long, she's very likely to bleed. You have to understand the risk and the balance between thrombosis and bleeding in these patients before you enter the cath lab. So I hope that all came across very well in Syria. I'm sorry I can't be with you in person. I'll try and take any questions if there are any. Thanks very much.
There was a question.
Prof. Kit, you are hearing me now? Still with us?
Yes?
So thank you very much for your outstanding talk. Believe me, I'm surgeon. I understand what you have to say. So it's terrible. So thank you very much for your talk. It was very interesting. I will let the talk for Dr. Bipa.
If there is any question here,
Any question in the hall? No? Which kind, there is our friend, which kind of antiplatelet using? Which type of antiplatelet?
Okay. Yeah, no, I get the question. Yeah. So if we're using DAPT, then if it's an elective patient, we tend to use aspirin and clopidogrel. If it's a ACS patient, we tend to use aspirin and ticagrelor. If we're going with a NOAC, like this patient, a NOAC with a single antiplatelet agent, then we usually, in our own practice, we use a combination of apixaban and clopidogrel. There is some data on using apixaban or NOACs with ticagrelor and NOACs with prasugrel, and it probably is safe. But because we're trying to minimize the bleeding risk, we tend to use a NOAC with clopidogrel.
Okay. Barakat.
Thank you for your presentation, and I would like to ask you about triple anticoagulant NOAC and clopidogrel or aspirin. You prefer clopidogrel rather than aspirin?
Well, if we do want to give triple therapy for some reason, because, for instance, you know, we've done a lot of complex PCI and we're worried that a single antiplatelet agent won't be sufficient, then yeah, we give a NOAC plus aspirin plus clopidogrel, and then we almost always withdraw one of the antiplatelet drugs at 1 month. Usually we would stop the aspirin and continue with the clopidogrel, but occasionally we do it the other way around. Occasionally we stop the clopidogrel and continue with the aspirin. But always stop the triple therapy after 1 month. Never go on beyond that.
Microphone, Barak. Mike.
Hello, I want to ask you a question, a technical question about the BCI that you have showed. Is it always safe to put a stent in the ostial circumflex without doing a crossover stent from left main? The second question is for circumflex only, or even in osteal stenosis we can put an ostial stent? We know that every ostial lesion the distal left main will be involved microscopically in atherosclerosis. So when you put a stent in the ostium, there's a high risk for recurrence or restenosis or maybe thrombosis. Thank you.
Yeah, it's true what you say. The ostium of the circumflex is a high risk area for restenosis, particularly if you do two-stent bifurcation technique. That's why you probably noticed that we used intravascular ultrasound. So we put in a 3014 biofreedom ultra, and then did proximal optimization with a short 3-5 non-compliant balloon, and then we checked the result to make sure that we had full expansion in the ostium. And even if you have one or two struts extending into the left main, that's never going to cause a problem. The problem in this case would have been if you go from the circumflex straight back into the left main, crossover stenting. I mean, you're going to have to at least do a kiss and balloon, and then if you get a dissection, you have to put another stent from the left main into the LED. You turn it into a complex PCI in a high bleeding risk patient, where you have to be very, very careful doing that, because if you continue with the DAPT too long, of course they will bleed. So I think the important thing is, it's a platform. The cobalt chromium ultra stent is great for post-dilatation. It's got tremendous overexpansion capability, and we check the result with ARVIS.
Yes, sir. Third question.
Another question, do you use the same regime for the Freedom Ultra, or?
Yeah, exactly the same. Exactly the same. It's still a polymer-free platform. It's exactly the same dose of drug. The difference, obviously, is that we've gone from stainless steel to cobalt chromium. So we've gained a lot in terms of lower profile, crossability, deliverability, but we've still got great overexpansion and radial force. But the DAPT regimes are exactly the same. You only need 1 month is more than sufficient.
Thank you for the lecture. And according to this trade-off of bleeding vs thrombosis, can we in some cases of high bleeding rate use drug-eluting stent, by example, or something?
Sorry, could you just repeat the question? I didn't quite catch that.
According to the trade-off, bleeding vs thrombosis, if in some cases which is
You mean a normal drug stent with a polymer rather than polymer free?
yes, there is high bleeding ratio, but also there is high thrombosis ratio for this patient.
Yes.
Can we in some cases use drug-eluting stent by example in these cases?
Well, I mean, the evidence from Onyx 1 suggests that the Resolute Onyx, for instance, is as safe as the Biofreedom, and it's got a permanent polymer. The only interesting finding from that study is that there's a difference in all-cause mortality, which could be play of chance, but it could be a beneficial effect of having no polymer. So I personally, in high bleeding risk patients, I still use polymer-free drug.
Thank you very much, Prof. Mike.
Okay.
I will list the mic for Professor Akhras. He will ask you a question and he will continue his talk. Thank you very much.
Sure.
Dr. Akhras.
All right, thank you. Thanks so much. Keith, I wonder if in that case presentation, if your patient was not in AF, what would have been your best choice?
It's a good question. She would, even if she wasn't in atrial fibrillation, she still had quite a lot of high bleeding risks. So psoriatic arthropathy, using non-steroidals.
Yeah, exactly, that's what I'm asking.
Yeah, it's not a major thing, so, but it's still a bleeding risk. So my inclination probably in that patient would still, and she's had a stroke, and she had thrombocytopenia. So even without the paroxysmal atrial fibrillation, I would probably still have gone with a biofreedom ultra. Yeah.
Thank you.
Thanks for the question.
Thank you.
Thank you, Doctor. Now we continue with Dr. Fawaz Lakhras, very known invasive cardiologist from London, UK, and he will talk about limitation of PCI in patients with small vessel disease. Dr. Fawaz.
Okay, thank you. Can you see me now? Can you see a slide? Can you see the slide on your screen?
Yeah, okay, no problem.
You see it?
See, okay.
Okay, الكل شيء بدي ابدا sorry كيس just few words in Arabic بدي ابدا بيترحم على شهداء الوطن اللي قضوا بالحرب الظالمة السورية وجراء الزلزال، وبدي بدعو الله سبحانه وتعالى بالايام فضيلة انه يشفي كل جرحانا ويعين كل من ضرر بهالأزمة هي. Now I start my talk, Mr. Chairman, gentlemen, I'd like to thank the organized committee for such an esteemed program and for inviting me to talk to this conference. The diagnosis of coronary artery disease has focused on the presence of obstructive epicardial coronary arteries. And it is estimated that at least 2 in every 5 male and female patients with angina referred for electrocardiography have normal or non-obstructed epicardial coronary arteries, with the rate, relatively speaking, higher women. Nonetheless, we all know that ischemic symptoms can be present in such patients, and ischemia with non-obstructive coronary disease, so-called INOCA, refers exactly to this category of patients who may have stable or unstable angina in this setting. Coronary microvascular dysfunction, CMD, and epicardial coronary artery spasm are the two recognized pathophysiologic mechanisms of INOCA. And the diagnosis with suspected INOCA. Symptomatic relief is the primary goal of PCI in stable angina. It is currently observed clinically. However, this doesn't appear to be always the case, and the question is why. Large randomized controlled trials and registries showed that up to 40% of patients had recurrent angina at 1 year PCI. The results of the ischemia study showed medical therapy versus angiography-guided revascularization has similar outcome. Furthermore, the other study, which is the first of its kind in terms of having placebo-controlled randomized trial of PCI in stable angina, and simply quite severe disease based on angio and on physiology. And it's a single vessel angiographical guided trial. There was no difference in angina frequency, and there was no difference in exercise time. However, the PCI significantly reduced the ischemic burden induced by stress echo, but this is only for the focal and not the diffuse disease. Coronary angiography cannot occasionally visualize a particular lesion or location, may have an overlap of vessel or shortening of lesion, routinely underestimate the severity of disease, and often due to lack of normal reference segment, and it provides information only on the contour of the coronary lumen. Coronary microvascular dysfunction and as a CMD or epicardial coronary atherosclerosis are well recognized and well documented as a physiologic mechanism of the matter. And again, are diagnosed in up to 4 and 5 patients undergoing invasive evaluation for suspected aneurism. Hello? Can you hear me? The coronary related disorder international study diagnostic criteria of microvascular and vascular angina. And now I use the national and European guidelines. There are 4 diagnostic criteria for this diagnosis. One is symptoms of myocardial ischemia, absence of obstructive coronary disease, objective evidence of myocardial ischemia, and evidence of coronary dysfunction. And these are really how you identify the microvascular and vascular angina. It's a long slide, but the message from this is to really set up the 4 criteria for making the diagnosis. And the diagnostic criteria, the definitive diagnosis of CMD is made if all 4 diagnostic criteria are met. However, one can suspect the diagnosis if the first 2 criteria are present and or criteria 3 or 4. In 2021, European and American chest pain guideline adopted these definitive and proposed a diagnostic evaluation pathway for patients with stable chest pain and suspected inoculum, including invasive and non-invasive testing strategy. Test selection, of course, should be guided by local availability and expertise. IMR remain the gold standard, and it's thought to be specific for the diagnosis of CMD. As I said, this CMD diagnosis could be made by invasive or non-invasive measurements. Can you hear me?
Okay, son, no problem.
Hello?
No problem.
Can you hear me?
No problem.
I'm sorry.
Okay.
Can you hear me?
Yes, we hear you. Yes.
Okay.
Yeah.
Have you seen the previous few slides or not?
Yes.
Yeah, okay. So, non-invasive measurements of microvascular function can be made by a stress test using the myocardial blood flow rate or the stress CMR using the myocardial perfusion reserve, or by using stress Doppler coronary flow velocity reserve. It can also be measured invasively by coronary flow reserve or by calculating the index of microvascular resistance. This is specific to the the microvasculature, and it is not affected by changes in the patient's hemodynamics. It's calculated or defined as the hypertonic mean distal pressure multiplied by the hypertonic mean transient time, and it is normally less than 25. So what about the second mechanism, which is the epicardial coronary artery spasm? This can be induced by intracoronary acetylcholine, and by definition, the diameter has to be reduced by 90% in the presence of angina and ischemic ECG. However, when angina and ischemic ECG occur without the significant epicardial constriction, the diagnosis is made. These measurements should be considered once intracoronary imaging has ruled out dissection or plaque rupture. In order to evaluate for microvascular and vasospastic abnormalities, coronary flow reserve should be measured, and the IMR index should be calculated. And in this case here, you could see that it is more than 25, it's abnormal. And if these being excluded, then coronary spasm can be tested. And you can see here the difference in the LAD between baseline and following intracoronary acetylcholine. This is compared to normal. In the absence of results suggesting microvascular disease, normal CFR or IMR, either one, and no epicardial stenosis, vasospasticity can then be assessed, as I said, in the picture here. And when you do ventricular angiogram, most of the time you may identify an epicardial territorial distribution of hypokinesia implicating a single epicardial artery, compared with a microvascular pattern involving a widespread and more extended territory of one or more coronary arteries. And as I said before, coronary angiography occasionally cannot optimally visualize a particular lesion and may have an overlap of the vessels and shortening, but it does not really give any information on the vessel wall, which may contain substantial atherosclerosis and positive remodeling. Functional FFR measurements, not putting back the recording or intravenous imaging, can be useful for optimal PCI with a given artery, or to identify the need for bypass as an alternative to PCI. In the absence of advanced hemodynamic and imaging, it is likely that many of these patients are misdiagnosed as having non-obstructive coronary artery disease. Although the cutoff point for FFR is less than 0.8, in order to determine whether a lesion would benefit from PCI or not, the risk of future events based on an FFR continuum. You can see here between 0.8 and 0.9, there's certainly quite a large sway of patients who have a much higher race than the subsequent one. And if it is between 81 and 90, or if the FFR is between 0.9 and 0.1, there's still some vessels, they do have some ischemic lesions. And I think, although it has not been proven that lesion with an FFR between 80 and 90 benefit from revascularization of these patients are clearly, these vessels are clearly higher risk than other vessels in the 80 to 90. these vessels are clearly at higher risk and perhaps should be managed more aggressively and should not be categorized as non-obstructive. As you could see, most of them here quite on the steep part of the curve, that they have certainly quite up to 20% MACE rate, and they're considered not suitable or not required for revascularization. I think we should concentrate on this on patients in this area because they certainly require probably maximum medical therapy. You may say that or think that the PCI was not successful. The patient still has symptoms. This area might explain the documented 40% or up to 40% of patients having the recurrent angina at 1 year. So we should not really ignore that part of the FFR measurements. As I said before, in cases of the IMR is the specific test for microvascular disease, and since microvascular and epicardial coronary disease can both influence clinical outcome, it is concerning that microvascular dysfunction could lower maximum hypertonic flow and therefore raise the FFR value, masking the severity of epicardial lesion. This is very, very important. And in case of concern, I think we could resolve to performing intravascular imaging, which could be extremely helpful. And as you know, many trials looked at patients with intermediate stenosis, 40 to 70%. The use of IVUS to guide revascularization was found to be non-inferior to FFR with regard to death, myocardial infarction, or revascularization at 2 years. Multiple lesions, overlapping stent and diffuse disease have been predictor of poor clinical outcome. And often operators do not bother to do diffuse disease by PCI, despite theoretically improving inflow pressure if proximal lesions are treated. Possibly that's by improving the flow, the microvascular will also benefit. However, this is being underscored in the recent study published in the New England Journal of Medicine, the REVIVE trial. So among patients with severe ischemic left ventricular systolic function who received optimal medical treatment in whom revascularization by PCI did not result in a lower incidence of death or hospitalization for heart failure. So PCI in small vessel disease is associated with increased risk of stent thrombosis, restenosis, and slightly to be induced or reduced coronary blood flow down these vessels. So it's drug protein stopped here. So drug-coated balloon DCB are emerging as an effective alternative treatment for small vessels. The Bella trial by Antonio Colombo reported a significantly lower MACE rate at 15% in those patients with DCB group compared to the and that's at 3 years. So it's 15 compared to 48. The stent was drug, the second group, sorry, it was a paclitaxel DCB or PS that was used in such vessels. The basket small 2 randomized study also found that paclitaxel DCB was non-inferior to paclitaxel everolimus DS at 1 year, 7.5 MACE against 7.3. Conversely, the SCAR raised the compared patient with small vessel disease treated with either paclitaxel DCB or neurodegeneration mentioned DS, a propensity score adjusted analysis showed a higher risk of clinical, I emphasize here, clinical restenosis in the DCB group compared to the DS group at 3 years. It's really quite a jump from 4.1 to 1.8. Microvascular dysfunction and microvascular obstruction are common in stable and acute ischemic heart disease. Coronary artery disease affects vasomotor activity of the distal coronary artery circulation, resulting in coronary microvascular dysfunction and chronic myocardial ischemia. The impact of CMD on angina and prognosis underscores the need to optimize medical therapy to treat residual CMD that may not be improved with PCI or surgical revascularization. You will still be left with the microvascular dysfunction, and also it might actually lead to refractory angina. So in conclusion, Mr. Chairman, ladies and gentlemen, colleagues, accumulating evidence demonstrates that clinical benefit of identifying pathophysiologic mechanism for diagnosis, prognosis, and tailored medical therapy in INOCA patients. And PCI in this setting is probably not the right therapeutic strategy. PCI may not correct microvascular issues, and occasionally it may transiently worsen the microvascular function. It seems logical, therefore, that if one improved the proximal lesions, there probably would be a better flow down the microvasculature. Despite the success of PCI in relieving stenosis in epicardial coronary artery, pre-existing microvascular dysfunction may inhibit sufficient myocardial flow and have a negative impact on residual symptoms. Hopefully, the ability to change epicardial disease, to manage epicardial disease, regardless of lesion length or vessel size, will ultimately result in symptomatic improvement in patients with combined macro and microvascular disease. Thank you for your attention.
Thank you, Dr. Fawaz, for a very nice through. Do you have any question here in the audience?
Thank you, Dr. Fawaz, for a very nice presentation. I would like to ask you about...
who is the speaker?
Ilyas Barakat.
Dr. Ilyas Barakat.
Ilyas Barakat. Do you hear me? Thank you for your presentation. I would like to ask you about the drug of shock for microvascular angina. You know, the new term for new angina, this is microvascular angina, this is a new name for angina. Do you prefer calcium blocker or beta blocker for treatment this phenomenon? Thank you.
I simply take calcium antagonist as a first-line treatment.
Calcium blocker.
Yeah.
Okay. Thank you.
Excuse me, there is a question from Dr. Ahmed Khadour. I think he's in Britain.
Yes, please. Can you hear me?
Yeah, okay, correctly.
اوكي شكرا دكتور فواز على يعني هو الاستاذ فواز هو علم من اعلام سوريا وبريطانيا وقدوتنا. استاذ فواز ما بعرف نحن عملنا بيبر السنه الماضيه بالوورد جورنال كارديوثوراسيك سيرجري لمرضى لاستعمال النيو تكنيك the ultrasound low intensity pulse ultrasound treatment for any patient minor candidate for surgery or PCI. ويمكن في هذول المرضى اللي عندهم microvascular disease بجوز في potential benefit of this technique. وهذا التكنيك next on 19th الحمد لله accepted as well بالبريتش cardiovascular meeting next Sunday. ما بعرف ممكن we elaborate this technique, this strategy of using ultrasound for this group patient of microvascular disease where is no place for PCI or surgery. شكرا. المرضى أخذوا 30 جلسة ultrasound ووجدنا بالدراسة تحسن بالإجكشن فراكشن بالثيكنس اوف سماكة العضلة القلبية وتحسن سريري بالكلاس نيها والسي سي اس. دكتور بعرف شو رأيك أستاذ فواز
Dr. Ahmed, sorry, Dr. Ahmed, I think I may have missed what was your voice was echoing. What was the pulse, what was it applying?
This technique is ultrasound wave shock انعطى بشورت اكسس على العضله القلبيه 30 جلسه.
اوكي فهمت.
30 جلسه خلال 30 يوم. وجدنا هي بتحرض الاندوفاسكولار جروث فاكتور. ووجدنا انه الكوليترال جرو ونتيجه هالتحريض هذا للاندوفاسكولار جروث فاكتور الكوليترال جرو سخانه العضله القلبيه عم تتحسن والايجكشن فراكشن عم يتحسن. مع الجروب اوف بيشنت اللي عندهم microvascular disease there is no place for surgery or PCI ممكن تكون استراتيجي للمستقبل we can elaborate this study further on this group of patients.
Where was it? How was it applied on the myocardium?
It's applied externally on this surface on chest surface. There is a probe, special special machine, ultrasound. And we put a probe on the chest and we give a pulse, 1 minute pulse, in short axis, 3 point. المريض بياخد 30 جلسة من 30 ل 35 جلسة خلال 30 يوم ونعمل ايكو ستدي خلال هالتريتمنت هي قبل المعالجة وخلال المعالجة وبعد منظم المعالجة. الميكانيزم هي بتعمل تحريض induction للاندو جروث فاكتور فاسكولار اندو جروث فاكتور وهي نشرت بالورد جورنال كارديوثوراسيك سيرجري last year.
You think it will have a positive impact on the individual dysfunction?
يعني ممكن تكون هالجروب اوف بيشنت ممكن تكون جود استراتيجي لما ما بيكون في بليس للPCI or surgery لهالجروب بيشنت اوف microvascular surgery with ischemia, intractable ischemia.
Quite interesting. Thank you very much, Dr. Hassan.
Excuse me, can I pose a question for Dr. Ahmed Khadour? Dr. Ahmed Khadour, you are hearing me? دكتور احمد من شي 10 سنوات اجانا عرض كوبي هون بمركز الباسل هو اكسترا كوربوريال اسيستنت ديفايسز هي يعتمد على اجهزه ضغط وعلى كل الجسم الاطراف العلويه والسفليه بجلسات 30 جلسه متابعه يوميا على نفس الحكي اللي عم تحكيه تماما. نحن كان لنا فائده واضحه بالنسبه للمرضى اللي كانوا مرفوضين بالنسبه للعمل الجراحي وبالنسبه للمرضى الريدو طبعا هم اللي كانوا كبار بالعمر جلسات على 30 يوم. انا بدي اياك تميز لي بين الاكسترا كوربوريال بالساتايل بريشر والميكروويف اللي انت عم تحكي فيه.
والله ما عندي خبره بالاكسترا كوربوريال. انا عملنا الدراسه نحن بالمشفى الاسد على هي الماشين كمباني زمر هي الماشين موجوده بمشفى الاسد الجامعي ومهندسه اسمها شذا طريفي هي عم تقوم هي قامت بالدراسه وعم تابعه ريكروتينج بيشنت عباره عن جهاز صغير محمول باليد حتى ممكن المعالجه تصير بالبيت اذا مريض ما فيه يجي على المشفى. بياخذ كل يوم جلسه لمده 30 يوم. ووجدنا بامكانك ترجع للبيبر اسمها ليبوس ultrasound treatment for ischemic heart disease. بالوصل كارديوسيرك سيرجري. اكسترا كوربوريال ما عندي فكره، بس البيبر طبعا كانت لأول دراسه على هيومن. الاكسترا كوربوريال التراساوند كانت على انيمالز، فهي كانت اول هيومن موديلز انعملت بمشفى الاسد الجامعي. وهلا هي اكسبتد، يعني راح اعمل لها برزنتيشن نكست ويك ويكند. اذا حدا انترستد يمكن في فاسيلتي ان تحضروا المؤتمر الجمعيه البريطانيه لامراض وجراحه القلب فيرتشوال ازواج.
دكتور فواز كان يسال سؤال صغير. نحن بيجينا بنعرفه اكس سندروم، هل التعريف تغير ام العنوان تغير؟ نحن نسميه اكس سندروم. كان اكس سندروم.
X syndrome. Yeah, we've done a lot of work on X syndrome. You have either slow flow phenomenon, that is where you see layering of the dye as it's propagating down the heart artery. You see in culture too. More common than in men. And sometimes, and I think now in retrospect, I think almost certainly it's a microvasculature problem. And I think it's not an easy problem to diagnose or to manage, but I think and not all medical treatment would work here. Simply, you should not use beta blockers, say for example, but I certainly use vasodilatory therapy, such as calcium antagonist or nitrate, or even our medication, but not the beta blocker. I don't know if that answers your question, Dr. Osman.
There is a question here, please. Can you give me a microphone? Without microphone, Mr. Can you give your name first, please? شو على التليفون؟ In Armenian, in Chinese, in Armenian. مساء الخير دكتور فواز.
الله يسعد مساك.
الدكتور أفضل خدشادوريان من حلب.
اهلا وسهلا فيك.
الله يباركك. شكرا على المحاضرة. بس
انا بس قديش مبسوط للمجموعة. انا لسه الباسل يعني بيمشي ماشي قدام مدينا سنين بتنام الصبح 11 بالليل وال6
11 بالليل صح؟ 11 بالليل مظبوط.
تفضل. سؤالي بيخص خاصة الدراج اليوتينج بالون. اوكي، مسموع صوتي؟
مسموع صوتك.
الدراج اليوتينج بالون قديش برأيك بالسمول فيسلز اللي قطرة 1.5 مليمتر مع إصابات شديدة، قديش برأيك يعني الريستينوزس فيها كتيرة قليلة وهي أحسن من العلاج الدوائي مثلا للسمول فيسلز؟ وقديش بلندن مثلا أو بمراكزكم تستعملوها؟ how frequently يعني بمراكزكم تستعملوها؟ شو عندك فكرة أو خبرة على الدراج اليوتينج؟ لأنه عندنا كم مريض very small vessels مع إصابات شديدة، يعني هم تقريبا اسيمتوماتيك وعم بنتابع نعالجهم بالدواء، بس لسه يعني ممكن نعمل لهم اختبار جاد نشوف إذا في اسكيميا ولا لا، بس عم بنفكر إذا نستعمل دراج اليوتينج ستنت، دراج اليوتينج بالون، ولا نتابع بالدواء. شو رأيك؟ شو خبرتكم بلندن؟ وشو قديش فريكنتلي تستعملوا الدراج اليوتينج بالون بلندن؟
سؤال كويس ومتشعب. اولا اذا الاعراض اذا الواحد يسيطر عليها by medical treatment, I think it's very difficult to achieve by using the DCB as well. Number two is, if it's failed to control the symptoms, I think you resolve to trying DCB 1.75 or 2 millimeter, even if the vessel diameter is small, but you're talking about 1 millimeter, I wouldn't bother. Now the third point, which is quite interesting, there are now some centers adopting the DCB only policy. In other words, using stent only when required, or if there's any hemodynamic compromise caused by dissection or so. But there are some centers now going solely and all the way by using DCB rather than DS. I don't know if that answers your question.
Yes. I will ask Dr. Yassin. Dr. Yassin. شكرا. تحياتنا دكتور فواز.
اهلين دكتور ياسين، يسعد مساك.
الله يسلمك يا رب. انا سؤالي هلا على الدواء تبع البالون. صار في هلا سيرولينوس للدواء وللبالون، دراك كوتيك بالون، وصرتوا تستخدموه ولا لساتنا على القديم؟ باكليكاكس.
باكليكاكس في ادرالونس نعم، كوتيك بالون. في ستادي عليها قريبا، ما كان في فرق بين الاثنين، بس في باكليكاكس في الادرالونس. نعم.
في إلي تعليق على كارديوسبيكت اللي هو عبارة عن أمواج فوق صوتية بيطبقوها عن طريق الإيكو لجلسات متعددة، وهي مثل ما حكى إنه ممكن يصير في عنا أوعية دقيقة، يعني بتحرض نمو أوعية دقيقة بالمنطقة اللي ما حسنا نعمل لا جراحة ولا توسيع. الجهاز اسمه كارديوسبيكت، وما بعرف يعني مبدأه نفس مبدأ الحصيات الكلوية، تفتيش الحصيات الكلوية. الترا ساوند. نعم.
دكتور فواز بدي اسال سؤال اخير، سؤال من جراح لا تستغربوا. الكومبيني قالوا ايه لا تستغرب، هذا اسئله الجراحين شوي هيك على جنب على طول. الكومبينيشن بين جريت فيسلز والسمول فيسلز، يعني مريض كوروناري عنده 3 فيسل ديزيز، سوى الكوروناري تريتمنت يعني الكابج ما استفاد، بيسووا له القسطره الكنترول انه بيكون مشاكل عوده الانجينا، وايز هي الفيسلز اللي تساوي كلياتها رني نورمالي. فاذا نحن رجعنا على التعريف اللي انت كنت عم تحكي فيه سمول فيسل ديزيز. طب نحن هالكومبينيشن بين السمول فيسل وجريت فيسلز، الجريت بمعنى الكوروناري والجريت بمعنى الاورطه، how to manage this problem?
It is, I think the problem has been around for a long time, but it's never been given the interest that it deserves. كلياتنا بنفرح انه والله اوكي الستنت is fully opened and even IVAS showed fantastic results. إذا المريض مثل ما شفت يعني 6 very large studies and registries showing up to between 28 and 40% of the patient still having angina a year after successful PCI. I think this is where one would have to turn into the microvasculature and try to concentrate and maximize treatment in order to achieve the symptomatic benefit. The epicardial arteries, they are your favorite, I know, and you like them big and decent. But unfortunately, life is not as such. You will have this and you will have the other. And your question certainly focus on the combination, which I've alluded to in my lecture, of the epicardial disease as well as the microvascular problem. If you remember from my last slide, I deliberately alluded to the microvascular disease when the epicardial stenosis was relieved by PCI, but you left with one is done and dealt with, and the other one is still present. And unfortunately, this had quite a negative impact on patient symptoms. And this is where medical treatment has to be very selective. It's not really, you cannot treat them the same way as epicardial disease. And I feel that there are a lot of patients around undiagnosed or diagnosed with non-obstructive coronary disease, non-obstructive coronary disease. I think we have to concentrate a bit more on the microvasculature because it's extremely important.
Okay, بشكركم جميعا. Thank you, Dr. Fawaz, for a very good presentation. We are waiting you in the basket.
شكرا دكتور فواز، ونتمنى المرة القادمة تكون بيناتنا مثل ما عودتنا دائما ان شاء الله. شكرا جزيلا.
انا سبنا جروب صعب هالمرة، بتعرفني بدي على المؤتمر الجمعي ومؤتمر الباسل غالي عليه كثير لانه صار له زمان ما انعمل، ومضيت وقت دائما بتذكره بسعادة بمخبر الباسل. بتذكر بننزل من 8 الصبح ل 11 بالليل. اتمنى ان شاء الله المؤتمر الجاي نلتقي قريب مع بعض فيس تو فيس.
اهلا وسهلا فيك. شكرا للجميع.
شكرا لكم. شكرا لمحاضرة يونيفارما.
اوكي بتسمع. معرضين في هدايا. السيد ايمن عم يحكي لي انه لا تنسوا تاخذوا شهاداتكم من مين ايمن؟ من الاستقبال تحت الشهادات. هي شو خزقها؟
منيح اللي زرعت
وهي اللي زرعت ندور عليهم.
مساء الخير. يسعد مساكم جميعا ويعطيكم الف عافيه. بالبدايه بهنيكم على نجاح مؤتمر الباسل بعد الانقطاع لفتره طويله، وان شاء الله دائما المؤتمرات القادمه بتكون بهذا المستوى العلمي المميز. طبعا بعد ما تفضلوا الساده الاطباء المحاضرين بهالمحاضرات المميزه والزخم العلمي الكبير، رح ناخذ فاصل صيدلاني فينا نقول نلخص فيه رحله الدواء من الالف الى الياء، اي من لحظه اكتشافه لحد ما يتوفر في الاسواق. معكم الصيدلاني أسامة الدمري، برودكت مانجر في شركه يونيفارما. طبعا بالبدايه دائما نحن ندرس الادويه ونشوف فعاليتها، تاثيرها على الاشخاص، اثارها الجانبيه، ولكن ولا مره سالنا حالنا هذا الدواء كيف بلش اكتشافه، كيف كانت دراسات لحد ما وصل لتوفره في الاسواق. يعني اذا فينا نقول نحن الدواء ما وراء الكواليس. حقيقه الدواء يخضع ما بيقلب ما في مشكله خلص. الدواء يخضع لرحله طويله من لحظه اكتشافه لحد ما يتوفر بالاسواق. طبعا بناء على هذا السلم بالبدايه بتكون مرحله اكتشاف الدواء وتطويره، ومن ثم الدراسات ما قبل السريريه اي تقريبا في الزجاج، ومن ثم الدراسات السريريه على البشر، ومن ثم الحصول على موافقه الFDA الى ان يتوفر في الاسواق. حتى بعد توفره في الاسواق الدواء ما بيسلم منه، بتصير في عنده دراسات بوست ماركتينج لحتى يشوفوا اذا في كوشن معين مثلا ما كانوا منتبهين له، لحتى طبعا يدونوه ضمن نشره الدواء. نبدا بقى بمرحله الديسكفري، اكتشاف وتطوير الدواء. حقيقه اكتشاف الدواء اذا فينا نقول ياتي عبر 3 أسباب: إما اكتشاف آلية جديدة لمرض معين وبالتالي اكتشاف دواء قادر على معاكسة هذه الآلية، أو دراسة المادة الدوائية على عدة آليات مرضية معينة للوصول إلى الاستطباب الأفضل لهذا الدواء، أو حتى اكتشاف أثر جانبي لدواء معين ممكن أن يؤدي إلى استخدامه كاستطباب في حالة مرضية أخرى. وأشهر دواء على ذلك دواء الميزوبروستول اللي كنا نعرف كان هو بداية لحماية المعدة من تأثير الحموضة، ومن ثم لقوا أنه هو يسبب إجهاضات أو تشنجات في الرحم، فصار يستخدم كمحرض للإجهاض. طبعا أبرز مثال حديث على اكتشاف دواء نتيجة وجود آلية جديدة لمرض معين هي مادة النيبريلايزين اللي كانت معروفة من سنة الثمانينات، وكانت من المعروف طبعا اللي هي منتشرة بأنسجة عديدة من الجسم مثل الدماغ والقلب والرئتين والكليتين والنفرون والجهاز الهضمي إلى آخره. ولكن عمليا تأثير النيبريلايزين على القلب اكتشف بعام 2014 نتيجة دراسة بردان يلي كانت على مثبطات اذا فينا نقول مثبت النيبريلايزين اللي هو الساكوبتريل، واللي لقوا انه تثبيط النيبريلايزين عم يؤدي لزياده العمر النصفي للناتريوتيك بيبتايد او الامتداد طارحه للصوديوم، وعلى اثره حصل دواء الساكوبتريل فالزارتان اللي هو الان يعني وافقت الFDA للاستخدام بقصور القلب. ففعلا كانت هي آلية جديدة لقصور القلب أدت إلى اكتشاف مادة دوائية جديدة. مثال آخر وهو الSGLT إذا فينا نقول يلي هي الSGLT1 والSGLT2 يلي كمان اكتشفت بالثمانينات بالصدفة لما لقوا أثناء دراسة النفرون الكلوي لدى الجرذان إنه القسم القريب من النفرون الكلوي عم يكون فيه معدل عود امتصاص للجلوكوز أكبر وفينا نقول أعلى تواترا من الأجزاء الأخرى من النفرون الكلوي، إذا أن اكتشف المادة الSGLT يلي كانت هي المسؤولة عن عود امتصاص الجلوكوز من النبيل الكلوي القريب. فبناء عليه صار في عنا زمرة دوائية جديدة هي مثبطات الSGLT2، وكان أول دواء هو الكانابيفلوزين اللي أخذ موافقة الFDA ب 2013، والداباجليفلوزين والإمباجليفلوزين وهو دواء إمبا 10 و25 ملغ بعام 2014. طبعا بعد اكتشاف الدواء يتم تطويره أي دراسة إذا فينا نقول الحرائق الدوائية أكثر، كيف يمتص الدواء، كيف يتوزع، كيف يتم استقلابه وإطراحه، ما هي الجرعة الأنسب لهذا الدواء، طريق الإعطاء الأنسب، هل هو عن طريق الفم عن طريق الحقن، التداخلات الدوائية، الآثار الجانبية لهذا الدواء أو الآثار غير المرغوبة، والفعالية مقارنة بأدوية أخرى. طبعا على سبيل المثال عن موضوع الاستقلاب كان اكتشاف بالدواء الكلوبيدوغريل، اول شيء كان في ماده ثانيه هي مستقلب للكلوبيدوغريل كانت لها تاثير مثبت للB2Y12 وبالتالي مثبت لالتصاق الصفيحات. لقوا انه هي الماده اثناء اعطائها عن طريق جهاز الهضم المعني صار لها امتصاص جيد وتوافر حيوي جيد، الى ان صنعوا طليعه دواء تخضع لعمليه اكسده بالمرور الكبدي الاول عن طريق انزيمات CYP الى ان تصل الى المستقلب الفعال، وبالتالي زاد التوافر الحيوي. هي كانت كلها نتيجه دراسات الماده الدوائيه، وبالتالي كملخص لمرحله الاكتشاف والتطوير هي مرحله طويله تستغرق سنوات عديده. طبعا عمليا الدواء يستغرق من لحظه اكتشافه للحظه توافره بالاسواق وسطيا 10 سنوات، طبعا 6 إلى 7 سنوات وسطيا تكون هي مرحله فقط الدراسات السريريه على البشر. طيب نحن نشوف أدوية دائما وبتواتر عالي بالأسواق، فينا نقول حقيقة إنه ثلثين الأدوية هي أدوية مطورة عن فينا نقول فرد آخر من العائلة الدوائية، والثلث الآخر هو دواء مكتشف جديد. على سبيل المثال كان في عندنا نحن العديد من زمر الACE inhibitor كان المكتشف بالبداية الكابتوبريل وغيرها، ولكن الهدف الرئيسي كان بعد اكتشاف هذه الزمرة من الأدوية هي زيادة العمر النصفي لهذا الدواء وزيادة الحب للجسم أو الليبوفيليسيتي لحتى يوصل للعصيدة الشريانية بشكل أكبر، لحد ما توصلوا إلى الآن لأحدث دواء فينا نقول من زمر الACE واللي هم الرامبريل والبريندوبريل. طبعا الرام بعياراته 8.5 وال5 وال10 لعمر نصفي طويل يصل إلى 24 ساعة، وبنفس الوقت انتقائية عالية للجسم وبالتالي تركز أكبر في العصيدة الشريانية. تبدأ بعد اكتشاف وتطوير الدواء مرحلة الدراسات ما قبل السريرية سريعا اللي هي بتكون طبعا في الزجاج أو في العضوية الحية ولكن على حيوانات التجربة. هي عمليا التجارب تكون هدفها بشكل أساسي تحديد الجرعة الفعالة من الدواء والجرعة السامة من هذا الدواء. طبعا على الرغم من انه الدراسات ما قبل السريرية هي دراسات سريعة الا انه تحتاج الى دقة عالية، تحتاج الى معدات والى طاقم طبي مختص، بصير هي دوكيومنتيشن لكل شيء عم يصير لحد ما ناخذ الموافقة على انه ننتقل من مرحلة الدراسات ما قبل السريرية الى مرحلة الدراسات السريرية على البشر. اللي بيصير فيه اول شيء تصميم للدراسه اللي نحن بدنا نعملها على البشر، بعدين بيصير فيه تقديم شيء اسمه انفستيجيشنال نيو دراج IND، ملف اسمه IND. FDA بتشكل فريق كامل لحتى يتاكد من هذه التجربه ومن ثم يتم تقديم الابلكيشن للحصول على موافقه FDA. فعمليا بعد ما يصير في عندنا اكتشاف الدواء وتطويره والدراسات ما قبل السريريه، كل هالامور هي يتم تجميعها بشيء اسمه ابلكيشن بعدة ملفات يتم تقديمها للFDA للحصول على الموافقة. فهي عملية لا تعتبر سهلة إطلاقا وتستغرق فترة زمنية طويلة ودراسات دقيقة وعميقة. إذا تقديم أول شيء الابلكيشن بصير في له ريفيو من الFDA إلى أن نحصل على موافقة الFDA النهائية ليطرح الدواء في الأسواق. مثال عليه دواء كان ديزارتان، دواء الديزارتان اللي حصل على موافقة الFDA عام 2005 لعلاج قصور القلب بعد دراسة شارمة اللي أثبتت خفض الوفيات ودخول المشافي بنسبة 23% لدى مرضى قصور القلب. دواء الارمي اللي حصل على عدة موافقات FDA حسب كل دراسة بالبداية أخذها بعلاج الهارت فيلير 2015 ومن ثم 2019 لدى الأطفال بدراسة بانوراما ومن ثم الكرونيك هارت فيلير بعام 2021 نتيجة طبعا دراسة باراجون. الأنبا نفس الشيء كان هو أول دواء للسكري يخفض الخطورة القلبية الوعائية أخذ عليها ب 2016 حصول الموافقة على FDA نتيجة دراسة إمباريج ومن ثم الهارت فيلر ريديوست ايجكشن فراكشن بعام 2021 دراسة امبرو ريديوست وامبرو ريزيرف بعام 2022 واللي حصل عليها على موافقة الFDA لعلاج قصور القلب ريزيرف ايجكشن فراكشن. المرحلة الأخيرة هي البوست ماركتينج أو بعد توفر الدواء في الأسواق يتم مراقبة المرضى اللي عم يستعملوا هذا الدواء سواء دواء RX أو OTC لحد ما يشوفوا إذا كان في تأثير ظاهر وما مدروس سابقا ممكن إنه ينضاف ككوشن كتنبيه او تحذير على استخدام هذا الدواء او انه احيانا يسحب من الاسواق. في كثير ادويه توفرت بالسوق بعد فتره تم سحبها نتيجه اكتشاف اثار خطيره ما كانوا منتبهين لها سابقا. طيب السؤال الاخير انه في الجمهوريه العربيه السوريه هل تتم كل هذه الاجراءات؟ حقيقه لا، هذه الاجراءات تحتاج الى طاقم متخصص. طبعا هو فقط في امريكا واوروبا. نحن في عنا عمليه اسمها الريجستريشن بروسيس، عملية تسجيل الدواء اللي تبدأ طبعا بمرحلة طويلة اللي هي أول شيء الابليكيشن تقديم على الدواء. ممكن إنه نحن نقدم على دواء متوفر في لائحة الأدوية السورية سيريان دراج ليست أو إنه دواء ما كان متوفر سابقا ونحن نضيفه على لائحة الأدوية السورية تحت اسم MDL أو النيو دراج ليست. طبعا لحتى نقدر ناخذ موافقة إدخال مادة جديدة إلى سوق الدواء السوري يجب أن يكون حاصل على موافقة الFDA أو الإنيا أقل من دقيقة لسنتين على الأقل، وبنفس الوقت توجد دراسات داعمة على ذلك. يتم بعدين اختيار الاسم المناسب للدواء وهي عملية ليست سهلة اطلاقا على اسم الدواء. تصميم العلبة، بعدين اخر شيء نبعث الطبخة الاولى من الدواء لحتى يتم فحصها بشكل دقيق من وزارة الصحة. العملية بتاخذ حوالي 3 إلى 6 أشهر ومن ثم يعطى الموافقة على تحرير الدواء في الاسواق. فعموما اللي انا بدي اوصل له انه نحن لما نقترح مادة دوائية جديدة للتصنيع في سوريا هي فعلا مرحلة معقدة ومدرسة بسهوله ممكن يتوفر الدواء في الاسواق لما نحن بصير في طلب له. طبعا هذا الشيء اللي نحن عم نذكره هو يحصل اما على الادويه الجديده او حتى الادويه المتحوله من براند الى جنريك. وزاره الصحه بترجع بتاخذ طبخات جديده وكانه دواء جديد وبتعمل عليها الفحوصات اللازمه لتحررها في الاسواق. وطبعا تفتخر شركه يونيفارما بانه هي اول من ادخل ماده ساكوبترين فالزرتان وقدمت عليه كنيو دراج ليست في الجمهوريه العربيه السوريه لحتى قدرنا نحرر دواء الارمي المفيد حاليا لكثير من مرضى قصور القلب. لتبقى دائما يونيفارما هي الجوده التي تثق بها. وشكرا جزيلا لاستماعكم.
يعطيك العافيه. شكرا.
دكاتره لو سمحتوا بس نحن في عنا سحب على المسابقات، عنا بس فقط 5 جوائز خلال المطعم. هو المطعم نحن ما فينا نروح بس اعطيني هذا ما راح نطول عليكم. دكتور يلا دكتور عادل ممكن تسحب لنا ورقه؟ شو الرقم والله دكتور؟ رقم 200 رقم جابوا 200 على الستاند دكتور كان في عندنا سحب بيمشي الحال. طيب يلا ما راح نطول نحن هلا. للاسف هو الفكره انه في اطباء كثير طلعت فيمكن يكونوا البطاقات 172 محاوله ثانيه. الدكتور محمود. طيب هلا الدكتور بس محمود معلش لانه ربح خلينا نعطيه جائزته. اعطيني الكيس الكريم. مبروك.